Friends, I am Dr. Hemraj Chandalia, working as Director of Endocrinology, Diabetes and Metabolism at Jaslok Hospital and Research Center, and at my center called Diabetes Endocrine Nutrition Management and Research Center. Dear friends, I'm going to speak to you today about the titration of insulin doses. Although you succeed in initiating insulin in a patient after overcoming the inertia in the initial acceptance, if you do not titrate the insulin and adjust it further, the patient does not get full benefit of insulin therapy. So therefore, it is very important that you set up the mechanism in your clinic to undertake this titration process or teach the patient to do that in order to get optimum results. So this first slide shows that titration is usually done in a stepwise fashion. Very rarely, for example, in type 1 diabetic, who's already had some difficulty before he or she sees you in insulin adjustments, then you right away start a basal bolus regime. As this first slide shows, in type 2 diabetics, very typical pattern of escalation should be done. For example, when the 3 potent oral drug combination has failed to bring about a good control of glycemia, then you will first introduce a basal insulin. And basal insulin, when optimized, and yet you find there is a severe prandial hyperglycemia at one of the meals, which may have been a large meal, then you introduce single shot of short or quick-acting insulin before that particular meal. This is called basal plus, where the 1 dose has been added. You further escalate and increase it to 2 doses, with 2 meals coverage, and in the end, probably you may require the 3rd dose. In type 1 diabetics, sometimes you will right away go to the basal bolus plan because most of them are very difficult to control with any other regime. However, there are exceptions, and sometimes the patient under partial remission may respond to single dose of insulin as well. But most of the time, you go straight to 3 doses. So after doing this basal bolus escalation, then you are going to go further and evaluate the person. And how do you titrate that dose further? We'll see. So the second slide shows you now the basic algorithms of this insulin dose adjustments. And then obviously, as I told you, if the A1C stays up about 7%, and if there are definite prandial peaks or very high basal, then you know that in spite of oral agents, the control has not been achieved, so introduce insulin. And when you do that, especially remember that with a continuing weight loss, which is not voluntary weight loss, but unintentional weight loss, there is an indication to definitely start insulin therapy along with the oral agents. Remember, oral agents are continued for the sensitizing effect. And then, of course, you see the algorithm go, as I told you earlier, into the basal, followed by basal plus, followed by the typical basal bolus plan. Now we will look at the process of titration more closely. So once you understood the concept of this stepwise escalation, and you come to now titrating insulin. Most important thing to understand is that before you start prandial insulin, please make sure that you adjusted the dose of basal very, very carefully and brought to the maximum required dose or optimum dose. Because underuse of basal insulin will foul your attempts to really get a very good glycemic control. So remember that in final insulin doses, the basal insulin makes about 40 to 50% of total dose, while the prescriptions we see very often are deficient in the doses of basal insulin, and therefore adequate control is never reached even after adding prandial insulins and adjusting them. So please exploit the basal insulin and its qualities before you initiate prandial doses. Now, we have decided to use prandial doses because the prandial glucose is yet continuing to be elevated, then how do you really titrate those doses? So you will always start low and go up. And the dosage changes are made roughly about every third or fourth day. This is the time required for a modified dose to manifest its full effect, and therefore it's the right time for you to embark upon the next change or next acceleration. So you do that, and you do, therefore, for example, most of the times we add 2 units in the doses where the prandial glucose continues to be high every third or fourth day. And we continue to do that until the prandial is correct. So you have already taken care of a fasting glucose by titrating the basal, and now prandial you start titrating in this fashion. So, but plus 2 units is not the final formula. I want you to understand that the escalation you make is really a fraction of the already dose being given. So the 10 units, you may increase only 2. But once you reach to a prandial dose, which is already something like 16 or 20 units at each meal, then it is not adequate to change it by 2 units. You start changing by about 4 units. So remember that most of the time it is 2 units in the normal dose requirements, but in large dose requirements, escalation also has to go fast, and it is something like 4 units with every dose. Also, you must know that the starting dose is often either 0.05 unit per kg, or maximum is 0.1 unit per kg of body weight. Because sometimes you wish to know where you start, and this usually ends up with a dose of 8 or 10 units in most of the patients in the beginning dose. There are patients who are extremely sensitive, and the children in type 1, if you are doing, they may have to use escalation of only 1 unit and sometimes 0.5 units. And for measuring 0.5 units, there is a low-dose pen which is made for children where 0.5 unit can be measured. Most of the insulin pens only measure in fractions of 1 unit. So this is how the escalation is made. It is very important sometimes to teach the patient how to titrate the dose as well. In many studies, this has been done very successfully. Patient has been given this simple concept which I stated for you, that this you start with and increase by 2 units now every third day if it is above the target, and you set the targets. Target setting is very important in diabetology. So you tell the patients that we want our fasting, for example, between 100 and 120 or 125, and there you are adjusting your major dose until you reach the targets, and the prandial is in the range of about 140 or 150 to 160, 70. So once you give the targets, then the patient can self-titrate, and some of these studies have shown very good results with self-titration. Thank you very much for your patient listening.